Hi everyone, welcome to PharmaGrid YouTube channel. The main aim of our channel is to share knowledge. I hope the videos we upload through this channel will be very helpful for all pharmacy professionals, especially those who are preparing for various competitive exams like KAPS, PEBC, DHA, MOH, as well as HARD. So let's start my first video with KAPS recalls discussion. In each video, we will discuss approximately 5 questions and the key discussion points. So let's go to the first question. Drug of choice for Q fever is? Options are amoxicillin, erythromycin, doxycycline, amikacin. We know that amoxicillin is an extended spectrum penicillin. Erythromycin is a macrolide antibiotic. Doxycycline is a tetracycline antibiotic. And amikacin is an aminoglycoside antibiotic. Okay, so here the answer is option C, that is doxycycline. That is the drug of choice for Q fever is doxycycline. Okay, so now let's discuss more about Q fever. Okay, so this Q fever is an infectious disease mainly caused by a bacterium called Coxiella burnetii. You will get this particular disease from dust or animal products containing the bacterium called Coxiella burnetii. Sheep, goats, cattle, and other animals can carry this particular microorganism, and it can get into the soil around them, allowing it to spread to people. This Coxiella burnetii can infect your lungs, heart, brain, bones, or other parts of your body and cause symptoms there. Some people have extreme tiredness or fatigue and other symptoms for months or years. This Q fever can be of two types, that is acute Q fever as well as chronic Q fever. Chronic Q fever can be life-threatening. Acute Q fever is usually treated with antibiotics, but chronic Q fever often requires combination treatment with antibiotics and anti-inflammatory medications. The usual combination used is doxycycline with a hydroxychloroquine combination. Then doxycycline is the recommended first-line treatment for non-pregnant adults with Q fever. So here comes the answer. That is the drug of choice for Q fever is doxycycline, and is most effective at preventing severe complications if it is started within the first 3 days of symptoms. That's the doxycycline is highly effective if it is started within the first 3 days of starting the particular symptoms. And then people with life-threatening allergies to doxycycline may need to consider alternate antibiotics such as moxifloxacin, clarithromycin, trimethoprim sulfamethoxazole combination, and rifampin. Okay, so the next question is, diphtheria is caused by? Options are Corynebacterium diphtheria, Coxiella burnetii, Mycoplasma, Pseudomonas. From the name itself, it's clear that the causative organism will be Corynebacterium diphtheria. Okay, so this Coxiella burnetii we have seen in the previous question. It is a causative organism for Q fever. Then Mycoplasma is also another type of bacterium. You might have heard about Mycoplasma pneumonia. So such kind of species are responsible for causing pneumonia. Then Pseudomonas is a multi-drug resistant organism. Okay, so here the answer is Corynebacterium diphtheria. So the diphtheria is mainly caused by the bacterium called option A, that is Corynebacterium diphtheria. Okay, so now let's see what diphtheria is. So diphtheria is a serious infection caused by strains of bacteria called Corynebacterium diphtheria that make a particular toxin. This bacteria can spread from person to person, usually through respiratory droplets like from coughing or sneezing. People can also get sick from touching infected open sores or ulcers. It can lead to difficulty breathing, heart rhythm problems, and even death. There are mainly two types of diphtheria. The first one is classical respiratory diphtheria. It is the most common type of diphtheria, mainly affects the nose, throat, tonsils, or larynx. The second one is cutaneous diphtheria. It is the rarest type of diphtheria, mainly characterized by skin rash, sores, or blisters. The peculiarity of diphtheria is that it is a vaccine-preventable disease, but multiple doses and booster doses are needed to produce and sustain immunity. That is, being vaccinated is the best way to prevent getting sick with diphtheria or spreading it to other people. And the cases of diphtheria are usually treated with diphtheria antitoxin as well as antibiotics like penicillin or erythromycin. That is, the treatment for this diphtheria is usually diphtheria antitoxin and antibiotics like penicillin or erythromycin. So, question number 3. Major toxicity associated with donorubicin is. Options are nephrotoxicity, ototoxicity, cardiotoxicity, and pulmonary toxicity. This donorubicin is an anthracycline antibiotic and an anti-neoplastic agent. Its major dose-limiting toxicity is cardiotoxicity. Okay, so here the answer is option C, that is cardiotoxicity. And this nephrotoxicity is mainly exhibited by drugs like aminoglycoside antibiotics, cisplatin, amphotericin B, etc. And this ototoxicity is shown by drugs like loop diuretics, aminoglycoside antibiotics, and chemotherapeutic drugs like cisplatin and carboplatin. And this pulmonary toxicity is shown by amiodarone, then bleomycin and busulfan. This bleomycin and busulfan, they are anti-cancer drugs. So this donorubicin is an anthracycline antibiotic and an anti-cancer agent. It's mainly used for the treatment of variety of carcinomas, including breast as well as lung, and for the treatment of acute lymphocytic leukemia and lymphomas. Its mechanism of action is by inhibiting cellular reproduction through interference with DNA replication, although it may contribute to the induction of cell death by increasing oxidative stress through the generation of reactive oxygen species and free radicals. So one of the important mechanism of action of this donorubicin is the generation of reactive oxygen species and free radicals. And this donorubicin shows two major dose-limiting toxicities, that is myelosuppression and cardiotoxicity. Therapeutic cytokines are used for the management of myelosuppression. However, anthracycline-induced cardiotoxicity is the major limiting factor in the use of donorubicin to treat leukemia and other cancers. The cardiotoxicity is believed to be associated with the oxidative stress induced by anthracyclines. So the main point is that irreversible dose-dependent cardiotoxicity is the most serious adverse reaction and is more common with donorubicin and doxorubicin. And this cardiotoxicity is mainly due to the generation of free radicals and lipid peroxidation. This dexrazoxane is the only FDA-approved drug for preventing anthracycline-induced cardiotoxicity. This dexrazoxane is an ion chelator. Okay, so there has been some success with the ion chelator dexrazoxane in protecting against the cardiotoxicity of donorubicin and doxorubicin. So this question is, benzoyl peroxide is used to treat. Options are psoriasis, acne, dermatitis, and scabies. Here the answer is option B, that is acne. This benzoyl peroxide is a topical medication mainly used for the treatment of acne vulgaris. So the answer is option B, acne. And drugs mainly used for the treatment of psoriasis include apremilast, biologic agents, keratolytic agents such as coal tar and salicylic acid, methotrexate, retinoids, topical corticosteroids, and vitamin D analogs. Then coming to dermatitis, there are different types of dermatitis. In case of contact dermatitis, we can use oral or topical antihistamines, counter irritants, astringents like aluminum acetate and calamine, then benzocaine, which is a local anesthetic. And for scabies, the drug of choice is permethrin. Benzoyl peroxide is an over-the-counter topical medication and it is also an FDA-approved prescription medication for the treatment of acne vulgaris. This benzoyl peroxide has mild sebostatic and keratolytic effects and it is most effective when used combined with other acne vulgaris therapies. Then how it improves acne? It improves acne primarily through its bactericidal action, where its oxidizing activity is lethal for Propionibacterium acnes. So the causative organism for acne is Propionibacterium acnes. A particular feature of this benzoyl peroxide is that it shows no bacterial resistance. So here comes the point, that is, in contrast to other topical antibiotics, drug resistance has not appeared to develop with benzoyl peroxide use. And the most common adverse effect associated with the benzoyl peroxide is its bleaching quality, potentially causing the discoloration of colored fabrics and bleaching of hair. Sometimes it can cause contact dermatitis also. And this benzoyl peroxide is available as both OTC and prescription formulations in concentrations of 2.5%, 5%, and 10%. The next question. The use of clozapine has been associated with the development of. Options are granulocytosis, tendon rupture, pulmonary fibrosis, ototoxicity. We know that clozapine is a second generation antipsychotic drug, and the major adverse drug reaction associated with the clozapine is agranulocytosis. So here the correct answer is option A, that is agranulocytosis. And the tendon rupture is mainly shown by fluoroquinolone antibiotics. And then pulmonary fibrosis or pulmonary toxicity is exhibited by drugs like amiodarone, anti-cancer drugs like bleomycin, busulfan, etc. And ototoxicity is shown by loop diuretics, aminoglycoside antibiotics, cisplatin, carboplatin, etc. So this clozapine is an FDA-approved atypical antipsychotic drug mainly used for the treatment of drug-resistant schizophrenia and to decrease suicide risk in schizophrenic patients. Then what do you mean by treatment-resistant schizophrenia? Okay, so the definition of this treatment-resistant schizophrenia is persistent or moderate delusions or hallucinations after failing 2 trials of antipsychotic medicines. So as I have already mentioned, this clozapine is a second generation antipsychotic drug which has high affinity for dopamine receptors D1, D4, 5-HT2, muscarinic and alpha adrenergic receptors, but it is also a weak dopamine D2 receptor antagonist. It has shown to be an effective antipsychotic with minimal risk of extrapyramidal symptoms. So one peculiarity of this clozapine is minimal risk of extrapyramidal symptoms. However, its clinical use is limited to refractory patients because of its serious adverse effects. So one of the major adverse drug reaction is agranulocytosis. So the risk of developing agranulocytosis is around 1% in patients who take clozapine. So what is this agranulocytosis? It is a condition in which absolute neutrophil count, that is ANC, is less than 100 neutrophils per microliter of blood. And this clozapine-induced agranulocytosis, which is a reduction in the absolute neutrophil count or white blood cell count, it places the patient at an increased risk for infection. Usually this condition, that is agranulocytosis, is most likely to occur in the first 3 to 6 months of therapy, but it can still occur after years of treatment. So the mechanism behind this condition is thought to be a dose-dependent and immune-mediated reaction against neutrophils. So the patients who are on clozapine treatment should be strictly monitored by lab testing, including complete blood count with differential count, to ensure agranulocytosis is detected and treated if it occurs. Thank you for watching this video. If you find these contents of the video useful, please share this to your friends also, and have a good day. Let's see you in the next video.